branching pattern of the ducts, how many ducts there are. It's not just one thoracic duct that you go in and find. And so imaging those ducts prior to the surgery may be beneficial to the surgeon in identifying a location where there is minimal branching in order to be able to have the best chance at ligating all those ducts and having a successful outcome. And we can even do the same sort of scan after surgery to go in and make sure that, yes, all those ducts did get ligated. And this is a non-invasive procedure. It's not like we have to open up the abdomen and catheterize a lymphatic vessel or inject a mesenteric lymph node. What I like to do is I use ultrasound and I guide a needle into one of the popliteal lymph nodes and just infuse contrast into that node. And that node takes that contrast up and it goes up the lymphatic system into the thoracic duct. And it's pretty amazing how fast that contrast gets up into the thoracic duct. It's just a matter of a few minutes. And so it's a little bit technically challenging in getting that contrast into the lymph node, but it's not an invasive type of procedure. And it has been described where you can just infuse it into the subcutaneous tissues in the perineal region, but I think that obviously would take longer to get up into the thoracic duct, and the opacification may not be as great. This is an example of a CT lymphangiogram, and we can see 3 separate lymphatic ducts here right on top of, or thoracic ducts here right on top of that aorta. And so we get much better detail on a CT scan as opposed to a radiograph. And then this is an actual case that I was involved in. This is the pre-surgical scan, and this is up in the craniomediastinum, and you can see all these small dilated tortuous vessels up there, and these are all little lymphatic vessels. And so you certainly don't want to try to go up into the craniomediastinum and ligate all those vessels, and that's why we go caudal-dorsally where there's fewer vessels to try to ligate. And so back in the caudal-dorsal portion of the thorax, again, in this dog, there's 3 separate vessels that were identified. And so this is where the surgeon chose to go in and do the ligation. We did do another scan post-surgery, and there was some contrast up in the craniomediastinum again, not as much as before, but when we went back to the surgical site, we can see that one of those ducts was not ligated, and so it was kind of unfortunate for the surgeon. Had to go back in and and find that duct and ligate it, but it's better than having a poor outcome and an unhappy client. Don't do a lot of abdominal CTs, and that's largely because of the prevalence of ultrasound exam. However, sometimes gas in the GI tract or bony structures can inhibit what we're trying to look at on an ultrasound exam. Really, the main types of studies that I see or I will recommend as far as abdominal CT goes is looking at mass characterization or extent of certain masses, like adrenal tumors that may have some invasion of the vena cava, or sublumbar tumors, trying to determine whether there's local soft tissue invasion, or intrapelvic types of tumors that we just can't see because of the bony structures of the pelvis. And there's also certain vascular studies that we will do abdominal scans on, portosystemic shunts, vascular thromboses like portal vein thrombosis, and then intravenous pylography exams like I showed you before. And this is just an example of a 10-year-old dog that presented with a history of constipation, difficulty urinating, had some muscle atrophy on one of its rear legs. So an ultrasound exam was done, and we identified a large hypoechoic mass in the caudal abdomen that was extending from the pelvic canal, but we weren't able to identify the extent of that mass because of the bones of the pelvis. And so a CT was recommended to determine the extent of the mass and whether it was something that may be surgically resectable or not. And we've got a scan of the pelvis here at different locations. This is just cranial to the hips, and we can see a multilobular mass here displacing. This is the colon here getting displaced to one side by the mass. A little bit further caudal at the level of the hips, the mass is now occupying the entire pelvic canal, and you can't really even see the colon there. A little bit further caudally, we still see the mass, and it's kind of partially protruding through the obturator foramen there, so the presumption is that it's putting some pressure on that obturator nerve, which would explain why we see this atrophy of the adductor muscles here on that limb compared to the other side. The mass was fairly well encapsulated, and they elected to try to go in and remove it surgically, and the surgeon told me that he got it all. This was not Dr. Kuhlman, by the way. Told me he got it all, but of course you're not going to get margins back there in the pelvic canal, and unfortunately this mass came back fairly rapidly. CT is really the best way for imaging bone. Not so much tendons or ligaments or cartilage, that's where MRI can be helpful. But as far as imaging bone, fractures, osteolytic changes in bones, CT is great. As far as bony tumors and osteolysis with radiographs, they're remarkably insensitive at detecting lytic disease. You need to have about 30 to 50% loss of bone density before you'll be able to see it radiographically. And so CT can detect bony osteolysis much sooner than radiographs. And this is an example of that. This dog, honestly, I don't remember why it presented, but skull radiographs were taken, and they were pretty unremarkable. A CT exam was done, and there's pretty severe destruction of the left side of the skull back by the occipital bone. And this ended up being a sarcoma off of a fine needle aspirate. CT is great for evaluating the elbows, as far as looking at elbow dysplasia, fragmented medial cornoid process. It can very easily detect the fragments in most instances, and early arthritic changes in the elbows. And this is an example of a 1.5-year-old male neutered lab with 5-month history of intermittent lameness on the right front limb. Very typical signalment and history for elbow dysplasia. Radiographs were performed, and I can see a little bit of sclerosis down here in the proximal ulna in that right elbow, but I don't see a lot of degenerative changes. I certainly don't see a bony fragment. On the left elbow, same sort of changes, but much less severe. And so we're kind of really left without a definitive diagnosis on the radiographs. And so CT was performed, and this is the right elbow and left elbow. This is the proximal radius here, the radial head, and then this is the ulna, the ulnar notch. This is the medial cornoid process, and you can see a large osteochondral fragment there at the tip of the medial cornoid process with an osteophyte formation here. In the left elbow, it's not as distinct, but there is a fissure line here and a smaller separated fragment on the left side. So always, whenever we're dealing with possible elbow dysplasia, we always image both elbows, even though the dog may only be lame on one elbow. This dog had bilateral FCPs. CT angiography, to talk about that a little bit, this is the use of intravenous contrast to image the venous structures and arterial structures in a certain area of the body. And the most common types of CTAs that we do are portosystemic shunts, are looking at arterial venous fistulas, pulmonary thromboembolisms, thrombosis, vascular ring anomalies in the chest. I shouldn't say the most common, I guess. Most of these are not done very frequently, but these are the types of studies that we would do pulmonary or CT angiography on. The most common of these would be an evaluation of portosystemic shunts. And there's a lot of different ways of imaging shunts. Ultrasound is probably the most common method of diagnosing portosystemic shunts, but this is very user dependent. You have to have a very strong you have to have a very strong understanding of the vascular anatomy in the cranial abdomen. You have to be able to use Doppler ultrasound and feel comfortable with that. So, but even if you can diagnose a shunt, it can be difficult with ultrasound to characterize that shunt very accurately. Usually you can determine whether it's an intrahepatic shunt versus an extrahepatic shunt, and that may be the most important type of characterization that needs to be done. But with extrahepatic shunts, knowing whether it's a portovenous shunt or a portoazygous shunt or some other type of shunt can be very difficult to determine with ultrasound. Nuclear scintigraphy and portoangiography used to be considered the gold standards for imaging shunts, and those have really kind of lost favor recently. Now the gold standard for imaging portosystemic shunts is really portal CTA or computed angiography. And it's very accurate, up to 100% accurate in diagnosing portosystemic shunts. It's very fast, it's non-invasive, and it provides great detail of the shunt, what kind of shunt it is, and where it's going, which might provide some more information to the surgeon, which could benefit with decreased soft tissue manipulation and decreased surgical time. Not saying that I recommend a CT scan for every dog that may or may not have a portosystemic shunt. I think that ultrasound is still the primary imaging method that should be used and what I would recommend. The cases where I recommend CT angiography are cases where I can see a shunt, but there's something weird about it and I don't know what it is. And if I think it might make a difference to a surgeon, then I might recommend a CT angiography to identify that shunt in a little bit more detail, where it's going, and give them that information. The other instance where I might recommend a shunt is where I can't find a shunt, but I see a lot of other things that make me suspicious of a shunt. And the clinical suspicion is really high for a shunt. And in those cases, it doesn't happen very often, but in those cases, then I might recommend a CT exam. And this is a dog, a 2-year-old Shih Tzu that presented for recurrent or recent urinary accidents in the house, and then it presented for straining to urinate. And a radiograph was taken, and it's really hard to see, even if you're up close. But there are two very indistinct opacities here in the distal urethra, which were suspected to be calculi. They just weren't very opaque. And so with the age of the dog and the history of the dog and the suspicion of some radiolucent calculi there, we started thinking, well, maybe there's a portosystemic shunt. And we did do an ultrasound exam. The liver was quite small. This is just the liver right up here. There was some very large calculi in the kidneys, which weren't identified on radiographs. There was even some calculi in the urinary bladder that weren't identified radiographically. The dog had a 149 level bile acids, and so shunts was very likely, but I wasn't able to identify a shunt in this case. And so we did do a CT exam. And it's a very easy diagnosis to make here. There's a large tortuous vessel connecting the portal vein right here up to the azygous vein here. So this is a portoazygous shunt. We can see it on the volume rendering image here as this blood vessel right here traveling up dorsal to the liver to the azygous vein. The last thing that I'm going to talk about briefly is interventional CT. And when I say interventional CT, I mean the use of CT to do guided fine needle aspirates and biopsies. And ultrasound's the most common method of doing this. We're all familiar with getting ultrasound guided aspirates or biopsies, or even just using ultrasound to help get a cysto. But the advantage with ultrasound is you can guide that needle in real time. You can see the tip of that needle as it's advancing into the lesion. However, sometimes bone or gas around the lesion may limit our ability to use ultrasound. And so in those cases, I like to think about CT as a potential method for obtaining a sample if it's needed. And when I'm doing thoracic or CT-guided aspirates or biopsies, I'm usually doing this in the thorax. Ultrasound can be used in the thorax for sampling mediastinal masses or even pulmonary masses that are located along the pleural margin of the lung. But any type of mass or lesion within the lung that's deeper than that is not going to be able to be identified with ultrasound. So this is just an ultrasound image of a lung. This is the pleural margin of the lung. There could be a large mass sitting right here, but because it's not right at the edge of the lung, we're not going to be able to see it with ultrasound. And so that's where CT can be useful. And in this case, we have a large mass in the caudal right lung lobe, but we weren't able to identify it on ultrasound because of this air in the lungs surrounding that mass here. And so we chose to do a CT-guided biopsy. I won't go into the technical aspects of doing that, but it's basically using a very remedial type of stereotactic imaging to guide the needle, position the needle, get the right angle of the needle, and advance that needle to a certain depth to make sure it's in the lesion before getting that sample. And so this is an image of the biopsy needle within the lung mass. Because we're usually having to go through some normal lung tissue to reach that lesion, there's oftentimes some complications. A mild amount of pneumothorax is not uncommon, and we see that here following the biopsy procedure. I've done quite a few of these studies or these techniques, and I've only had a couple cases where the patient actually had to be tapped to remove the pneumothorax. I've never had a life-threatening complication. So even though we are going through some normal lung, there are risks associated with it, but sometimes getting a diagnosis is worth that risk. This is another example, a tracheobronchial lymph node that we did a fine needle aspirate of. You can see this kind of soft tissue track along the needle track. That's just some pulmonary hemorrhage along the needle track, but I've never seen, knock on wood somewhere, really severe hemorrhage as a complication. It doesn't always have to be the thorax. This is a dog with exophthalmos, and we identified a large retrobulbar mass here in the region of the zygomatic salivary gland, and so we were able to do a CT-guided aspirate of that and make a diagnosis of sialadenitis as opposed to neoplasia, and this dog responded well to antibiotics and steroids. And so, lastly, when should you consider CT for your patients? There's different things to consider in making that decision. Are other imaging modalities sufficient? Do you need CT, or can you make the diagnosis with radiographs or ultrasound or some other way? Will CT provide additional useful information that might make a difference in determining the prognosis or determining a treatment plan for that patient? Then there's always the cost-benefit ratio that has to be considered as well. That's really all I have. This is just kind of a fun case. When I was in Chicago, I used to get a call every once in a while from Dr. Catherine Gamble, who is the head veterinarian at Lincoln Park Zoo, and she would ask me if I could help image one of their residents, and so I've got to help out with some interesting studies doing that. This was Morgan the tortoise, who presented with a left rear limb lameness, and this 3D reconstruction doesn't really provide a whole lot of information about the lameness. It's just kind of a neat thing, although This left rear leg is for some reason not extended as far as the right rear leg. I don't know how significant that is, but when we look at the axial scans, we can see some pretty significant erosion of that coxofemoral joint on the left side. So I'm not sure what you do with a tortoise with DJD of the hips. Yeah, there you go. But that's kind of a fun study to help out with. And that's all I've got. I'm sure there's time to take a few questions if there are any. All right. Thank you very much.
I'm going to have at least one question, so I'll ask it.
Sure.
Over the course of your career, last 15, 20 years, do you feel like there's an increased client demand and acceptance of CT, or is it static, or how, or even from the perspective of how do we promote it a little bit more in primary care and especially emergency care? Like what are your thoughts on that?
Sure, I think that's a reasonable question, and yeah, I have seen an increased acceptance and an increased number of studies being done. When I was a resident at University of Wisconsin, we had a CT machine there. I think probably 3/4 of the studies were either just doing heads or backs, but as we see this evening, there's a lot of other things that can be done with CT and just getting the word out there and promoting CT more and talking to clients and at least presenting it to clients and not making the assumption that CT isn't something that they're going to pursue, because I think when clients see the benefit of CT and getting a diagnosis quickly or more quickly than perhaps just repeating radiographs constantly or doing other types of studies that have been inconclusive, that they might see the benefit of that. And so, yeah, it's definitely something that I've seen a large increase in demand in.
Questions? Thank you, Jason,
Okay.
for your expertise. Don't forget there are 1,000 sandwiches back here, so if you don't eat 2 or 3, you can leave. And there's CE certificates. Are they just filling
They're
in?
not personalized,
Okay.
you can just grab one on your way out.
Yeah, they're back here. We'll put them in a couple files. Looking
Oh,
around.
okay. And
Fellowship.
Nathan?
I think so. I might camp on the way home. Sort of my home. I had
You're what?
I might camp on the way home.
Oh, okay.
I might
Oh, yeah.